Hello to everyone at Better Senior Living. My name is Randy Beckett. I'm a psychiatric nurse practitioner, and I've been working with Encounter Telehealth since 2014. I'm a provider and I see patients, and I'm also the clinical expert, I guess you could say, for Encounter Telehealth to help you all in any way that I can and that we can help your residents and staff and families of your residents. So thank you for taking the time to watch this today, this introduction to how we render the services and some tips for you to help things along. So as you know, since COVID, telehealth has really taken off, and it's a wonderful service to be able to provide in-house psychiatric care for your residents and not have to have them travel anywhere and literally bring the service right to their rooms. So thank you for starting this. It's a wonderful thing for everyone. So the first thing we like to talk about is who is suitable for psychiatric evaluation and treatment. And one of the first things that you can do to help the process along is that when you have new residents admitted, that it would be great if you would include our consent in the initial paperwork that the resident, their guardian or POA signs upon admission. And this is because although they may not need psychiatric evaluation immediately, and I'm going to help you with some ideas to figure out who does and who doesn't need evaluation, but they may need it down the road. Because as we know, people who had a stroke or had a heart attack have a high risk of depression and anxiety, any kind of very serious health event, and that also moving from their home or wherever they were into long-term care, there can be some transition stress. So they may not need an evaluation right away, but if you have it signed and in their chart, then if they do need it, you'll have it. You won't have to chase anyone down, and we can get them seen quickly to address their need. So that's the first thing that's important and useful. And we've just seen that has worked in the other many facilities where we see folks. The other thing is identifying who is suitable for a psychiatric evaluation. And in your packet of information, your welcome packet with us, you will see this form, okay? And it is a template for how you can identify people that are in need of a psychiatric evaluation. And so we're going to talk about psychiatric evaluations, but also remember that we have teletalk therapy or psychotherapy providers too, because we know that talk therapy combined with medication is more effective than either one alone. And sometimes people need medication just to get to the point where they can participate in talk therapy. So, but what we're going to do is talk about some ways that you can identify who needs to be seen. And the first thing is that you are going to have a notion of who's depressed or who is anxious. You're experienced, you've seen this before. Everybody from dietary to housekeeping has ended up referring through nursing, of course, and their providers to us because they see something is off with the resident. Martha's just not as outgoing as she was when she first came in. She just seems down when I go in to see her therapist everybody. As well, of course, nursing and even administration can see this. So just your innate sense of when someone is depressed and your experience or anxious or having a mental health issue is the first way that you can identify who needs to be referred for an evaluation. Of course, and then there's acute crisis where people become psychotic, hallucinations, delusions. They have behaviors, agitation. They become hostile. They're starting to resist cares. Their whole mood has changed dramatically. That also indicates a need for a psychiatric evaluation. And then there's some very concrete ways that you can tell if someone needs a psychiatric evaluation. And in this form, which you will have in your packet, the first thing that you can do upon admission or as we come into a facility, and you can go through your residents' charts and see what medications they're on. Of course, an immediate need often is if someone is on an antipsychotic. As you know, there are 3 diagnoses that CMS has approved for the use of antipsychotics in a nursing home. Assisted living doesn't have these regulations, but of course nursing homes do. And those 3 diagnoses for the use of antipsychotics are schizophrenia, Tourette's, and Huntington's disease. And they have these 3 restricted diagnoses because there is a black box warning on all antipsychotics that says that elderly people, particularly those with dementia, when given antipsychotics, have an increased risk of death from cardiovascular disease. And so that is a huge deal. And so we want to only prescribe these medications to people who can benefit from them. So there are other problems besides those 3 of schizophrenia, Tourette's, and Huntington's disease that antipsychotics are approved for by the FDA, and this includes bipolar disorder, schizoaffective disorder, or other mood disorders. And that, although they can be indicated, if someone is on an antipsychotic and they don't have one of those 3 diagnoses, that's a good reason to have them evaluated and maybe prioritized, because often in hospitals, people will be put on a drug like Seroquel, which is an antipsychotic for sleep. And, there are alternatives. So we want to not increase the risk that somebody's going to have a cardiovascular event by having them on these medications. And then also we're concerned about your quality measures. This impacts you as well when somebody is on one of these medications and they perhaps can have their symptoms managed better and not be on an antipsychotic medicine. So if we can safely reduce these medicines, we want to do that. And that requires a psychiatric evaluation. Antidepressants, sertraline or Zoloft, duloxetine or Cymbalta, Paxil or paroxetine, Prozac or fluoxetine, venlafaxine or Effexor, Buspirone or Buspar, bupropion or Wellbutrin. All these antidepressants. A frequent one is mirtazapine or Remeron. That's a signal that this person needs an evaluation, because people who are on psychotropic medicines should be managed by someone who's trained in psychiatry. Anxiolytics, these are the benzodiazepines like Ativan, clonazepam, and Xanax. Those people should be evaluated. Sedatives, sometimes people are given a sedative like even hydroxyzine, which is an antihistamine, is used to treat anxiety and sometimes get people to sleep. Hypnotics like Ambien or Zolpidem, Lunesta, these other drugs are an indication for a psychiatric evaluation. Neuroleptics, anticonvulsants, gabapentin is one. Lamotrigine, okay, lithium, all these other mood stabilizers and medications need evaluation and monitoring. Stimulants, we really don't see this much in our population. Not many people are on Adderall or Ritalin. And then the anti-manic or bipolar drugs and mood stabilizers, as I mentioned before. So those are all medications. Now, interestingly, recently CMS said, well, we're not just going to go by what is the classification of this drug, but we're also going to go by the intent. And this is new. So if somebody is taking hydroxyzine, which is an antihistamine for anxiety, that it's not that they don't need to have like gradual dose reductions and they don't need to have these drugs monitored. We do, and they're going to hold us to it because it's being used for a psychiatric condition. Okay, melatonin, a supplement, insomnia related to depression, anxiety, mood disorders, schizophrenia, a lot of things. That needs to be monitored. Somebody might be using Benadryl for, sleep. So all these medications with their intent is what CMS wants us to monitor. So that's really, really important that we do that. And then we have diagnoses that you can filter through to look at. And you have this document. So all these different ICD-10 codes for all these different diagnoses. And many of these people, if they do have these diagnoses, then they are going to be a PASS-R level 2 and need to have an evaluation. So schizophrenic disorders, bipolar, anxiety, cognitive problems, dementia, of course, those people should have a psychiatric evaluation. A substance use disorder, we get a fair amount of alcohol-related dementia or other substance use disorders, and just a variety of other common diagnoses that will be in your system that you can take a look at and see if this person has a diagnosis or is on one of these medications, which indicates a need for a psychiatric evaluation. So take a look at this, distribute it, copy it, and make sure that everybody understands that these are the folks that you're going to refer for an evaluation. Okay. So also, I want to talk about several other issues. I'm going to stop the share here. And that is, let me enlarge this. The process. Okay, so when somebody is referred, you're going to contact our office. You have the consent sign, and then you're going to let us know the patient's name, their date of birth, and then if we have access to point-click care, then our office staff can look in point-click care and get all the demographic information, as well as the patient's diagnoses, allergies, medication list, that we need to build a chart for them for their initial visit. So depending on your process, we can access that directly through point-click care, or you can fax the information, send the consents over. And often the consents can be in point-click care and we can access them there. So then you'll schedule an appointment with our office and you will have a provider, one provider per facility for consistency and continuity of care. And then that'll be scheduled. And we like to block schedule so that, let's say you have 3 patients, new patients that you want seen, and later on follow-ups. But if 3 patients that you want seen, new patients, those are booked for 60 minutes, and we would schedule those all in one afternoon or one morning. And then the process is that you will have our iPad and you will log into the app that we're using for telehealth. And then we can see when that's up and you're on, and then our provider will call. And then with the provider, you will go through your concerns related to the resident, what problems you see, and the provider will either have information that they've gleaned from PCC originally, or you can go over that information with them at that time. And then if you say you have 3 new patients scheduled in that morning, then you'll go over all that information first, schedule a follow-up appointment based on, an approximation of what's going on. If someone is acutely ill and is agitated and has been hostile and physically aggressive towards staff or other residents, the provider might start a medication right then and follow up that week or the next week. If they don't need that close a follow-up, it could be in a couple of weeks or a month. And so we'll schedule those appointments so you can mark those down when they are, and then plus that appointment will be on the clinical note that we're going to send you when the visits are over. Okay, so you're going to go over all this patient information with your provider, and then when you're done, you will take the iPad and go and to the patient's room. You can also bring people into one of your offices, either way. And if the patient's really hard of hearing, the telehealth coordinator, the person that you've designated to help us, or the alternate telehealth coordinator, can stay in the room. Or if the patient has a problem expressing themselves, maybe you might have to translate a little bit. They have some sort of expressive aphasia or dysarthric speech, so that we can understand what they're saying. And like I said, that initial visit's going to be a little bit longer. Follow-up visits won't be nearly as long, as we're checking in to see how they're doing. And then if the patient doesn't have any impairment and can just have a conversation for that initial visit, then you can leave the iPad and go off, and then the patient can ring their call light when it's time to come back, a resident, and then go on to the next resident and so on. And then when you're done that day, you will get the note. We will electronically prescribe any medications, and in the clinical note or progress note that you get from us will be any orders like medication changes. And you can upload that into your software. For follow-ups, it's basically the same thing. You're going to have your appointment scheduled. So let's say we saw 3 new patients today. None of them are really acutely ill. They don't need to be seen in a week. They can be maybe seen in 2 weeks or a month. And so we will schedule them, all those 3 in the same block of time. It's just more efficient, especially for you that way. Just have a set amount of time. And then we will do the same thing. You turn on your iPad, log in to the app. The provider will call you. You'll go through the same workflow of talking about the issues or concerns that you might have with that particular resident. Discuss any medication changes that were made or need to be made, and then make a follow-up appointment, and then same process, go see the resident. This is very efficient, and we try to minimize, because your time is valuable, minimize the amount of time, but also take the time that's needed to get information from you and from the resident. And if the resident's family would like to join, they can join through the app. If they want to join remotely. Sometimes it's just a phone that they want to call in on, and just set the phone next to the computer, and they can listen and ask questions because we can hear them, of course. Or they can be there in person if they like. We can meet with them before we meet with their loved one, or during or after, whatever best for them. We want to make sure that we keep them fully informed of what's going on. If one of their primary care providers wants to, excuse me, speak with our provider, that's perfectly okay. We enjoy collaborating. So that's the process. And if you have questions with a resident during the day, normal workday, either contact our office on the chat in our telehealth app, and they'll get back with you, or contact the provider. You can put what your concern is, or you can call the office in Omaha, and they can solve your issue then, or address it, or get a hold of the provider to get back in touch with you. If it's after hours, then of course we have an answering service that you call the main office, and they will be forwarded to the answering service. And if it's a routine thing, it's a Friday evening at 6 o'clock, and somebody wants to make an appointment for somebody, the following week or whatever, and get back with you on normal business days. If it's a more urgent matter requiring a provider's attention, then they will go through the process that we have to contact the provider, or if that provider is not available, someone who's covering for them to get back in touch with you. For new patients, we really strive to have them seen within 48 hours if that's necessary. Okay. And if you need to have somebody seen sooner, there's somebody who's suddenly acutely ill, they're psychotic, or they're saying that they're having suicidal thoughts, or they want to hurt other people, or they're being really hostile and aggressive. If the provider that's assigned to your building is not available at that particular time, then one of the providers will see the resident as soon as we possibly can, and then transfer care over to your regular provider. And then also, of course, we have psychotherapy. That's a little bit of a different visit, where we're not going over medications. We're not discussing medications. You can just tell the psychotherapist if any concerns that you have, and take the iPad into the room. And of course, people have to have a certain level of cognition to be able to participate in psychotherapy. So if they have a moderately severe dementia, it's unlikely they'll be able to participate. If of course, if they can't speak, unless they have another way of communicating with a alphabet, a word board or something, with somebody there helping them, then that's the way you can do that. But normally, they're going to be conversant enough to have an effective psychotherapeutic encounter with our provider. So we really want to help as much as we possibly can. But we want to help with your GDRs. Please forward your GDRs to the office in Omaha, and they will get it to your provider. We want to decrease medicines as much as we safely can, because we are firm believers that if a medicine isn't effective, or if it's unnecessary, I've seen people who have been on an antidepressant for decades without any adjustment in it. We need to evaluate that. And of course, we want to do that safely, but we also want to minimize medications if they're not necessary. So that's going to be an important part. It's called deprescribing, of doing dose reductions when possible and not contraindicated, and adjusting medications, monitoring the medications, and that's what we're here for. So thank you very much for your time. This is meant to be an introduction. It should be a pretty good interview. There is lots of information in your welcome packet, and please use that and contact our staff for other questions. And we're so happy to be able to help you and your residents and your staff and the families enjoy better mental health, because it's much better for the residents. Their family gets to enjoy them more, and it's easier for you, the staff, to take care of folks when they're mentally healthy. Thank you very much.